Dr. Abbey Kruper. So Dr. Abbey Kruper is an associate professor in the Department of Obstetrics and Gynecology and the Department of Psychiatry and Behavioral Medicine at the Medical College of Wisconsin. She received her bachelor's degree at Marquette University and then received both her master's and her doctorate degrees at the Illinois School of Professional Psychology. She is a clinical psychologist who is embedded within the OBGYN clinics, which is just such a fantastic way to set things up. She does clinical research on behavioral health and obstetrics and gynecology and has presented both regionally and nationally in this area as well. I had the opportunity to work with Abbey for several years. She was embedded within our maternal fetal medicine clinic, and it was such a game changer for so many of our patients who really hadn't had easy access to those types of services, in particular for anxiety, which I know has been her clinical focus for quite some time. And so I would like to go ahead and hand it over to Dr. Kruper.
Wonderful. Thank you for that. I'm pleased to be here, and this seems like such a great offering to have available. So I appreciate the invitation. Let me just kind of do some things on my screen and then we'll get started. I'm assuming you can see my PowerPoint and everything is good as we cruise forward. Wonderful. All right, we're going to jump in. I'm happy to take questions as we go. So you're welcome to, pop your mic on or certainly have discussions at the end or the chat, whatever is most convenient. Some general objectives. So I'm going to touch on just anxiety in the perinatal context. We'll go through some specific anxiety disorders, really highlighting some of the unique perinatal factors of that, as well as substance use. Because I'm a psychologist, I'm a behaviorist, so we're really going to look at some of the core cognitive and behavioral processes that underlie anxiety and kind of perpetuate the cycle for women. And then some skills to support women as healthcare providers yourselves. So what is anxiety, right? When we're talking about anxiety, we really want to think about more of the clinical disorder diagnosis, not stress, which is such a general construct that encompasses quite a wide range of negative emotions. With anxiety, we're really talking about kind of that faulty fight or flight system. We all have it, we all want it, right? If we're in danger, in actual danger or threat, we want that system in our body to click on in order to keep us safe. We want to be able to mentally register the threat and then physically respond to that and keep ourselves safe. The challenge is that our mind has evolved and we're just now really great storytellers, thinkers. We picture and imagine things. And so now we can create even just the perception of threat or danger around us, but our body is still pretty primitive. And so it doesn't matter whether we're in actual danger or perceiving danger, that fight or flight system kicks on and the individual is responding to a threat, even if it doesn't really exist. It's kind of at the core of all of these anxiety disorders that we'll touch on, and really important for treatment to try to kind of unlearn or walk back some of those kind of faulty switches that are clicking on. From puberty to about age 50, women are twice as likely as men to suffer from an anxiety disorder. And anxiety does complicate pregnancy and postpartum, honestly, to a rate higher than depression. But I think historically the focus has always been on depression and postpartum depression specifically, leading anxiety in the perinatal period to be under-recognized and ultimately undertreated. But it has adverse maternal fetal outcomes and consequences, and I'm sure none of this information is new to the attendees in this talk, right? We know that untreated mental health, either through the direct physiological factors for maternal or the indirect maternal health behaviors and parenting behaviors, we see these adverse outcomes from a pregnancy perspective, infant, and even kind of years beyond in child development. We'd also probably see a pretty similar graphic if we're looking at the adverse consequences of substance use disorders. And so this is a significant concern that we want to be addressing for women to promote their outcomes. It's not just a quality of life issue, but it's really easy to kind of downplay it, right? It's stress, it's anxiety, it's normal. We can minimize it a little bit. Women can kind of, again, really just downplay the significance of it. But we want to appreciate that, again, when we're talking about more of these anxiety disorders, it does come with the consequences. Sometimes when I'm working with women, they might have pretty clinically significant anxiety, but they don't want to start a medication because they're only looking at the perceived risk of that medication. And so they're looking at it like it's either a risk of this medication or no risk. But what they have to start kind of shifting their mindset to is comparing the risks of medication to risks of untreated mental health. And we know all of the data that supports that. So that really starts to kind of help women shift into that mindset of this is something relevant and significant that we should be treating. Certainly kind of the pathophysiology and risk factors for developing perinatal anxiety is multidimensional. The most robust risk factor is going to be a personal or a family mental health history. But these are some of the other factors, including pregnancy-related, kind of past pregnancy loss, things of that nature, and those psychosocial contexts that can really predispose women to perinatal anxiety. Those women at risk of an exacerbation of anxiety in the postpartum period are going to be women that have a history of depression, those that are experiencing OCD symptoms in pregnancy, or those that have an intolerance of uncertainty. Now, I don't know that I've ever met anyone that says, I love uncertainty. I love not knowing. I love the unknowables and uncontrollables in life. It feels so good. So it's really understandable to not enjoy the uncertainty that can come in one's experience, but we're really talking about a much more significant intolerance of that uncertainty and maladaptive responses coping with it. And I'll expand on that a little bit later. Anxiety and substance use, again, probably not surprising, highly correlated, and the relationship is multifaceted. Anxiety is a risk factor for developing substance use and can impact the presentation and course of such. And then kind of using substances and that pattern of chronic intoxication and withdrawal can lead to anxious symptoms. Women are at greatest risk between the ages of 18 and 29, which can appreciate is kind of prime childbearing years potentially. The most common substances that women are using: tobacco, alcohol, and cannabis. Women tend to use substances for like weight control, fighting exhaustion, coping with pain, or attempts to self-medicate. So while rates are a little bit lower in pregnancy, they definitely normalize in that postpartum period. A lot of the data really looks at kind of anxiety and substance use, both as like standalone kind of concerns, but obviously that we know have that high correlation and relationship and both influence one another. And that's going to be the same when we think about treatment. A lot of evidence-based psychological treatments kind of exist for anxiety and substance use, but certainly kind of using them together in conjunction to treat is going to be ideal. All right, so let's go through a couple anxiety disorders, again, really highlighting the perinatal context and any substance use factors. When we think about anxiety disorders, comorbidity is the rule, not the exception. So it's not uncommon that women can meet criteria for 2 or more disorders, at any given time. There's a lot of overlap between symptoms, and you'll be able to maybe appreciate that. Certainly at different times of their life, they might also just meet criteria for different anxiety disorders. Because again, sometimes that underlying process as far as what's driving kind of that anxious response can be the same, and it just kind of changes how it might manifest. Generally, we can view it as it being anxiety as kind of that interaction between a biological vulnerability and the interaction with a stressful environment or an environmental event, some pivotal event. So certainly kind of having that genetic predisposition and then going through the profound transition of pregnancy and motherhood can certainly be kind of those combination of factors that really highlight anxiety for a woman. And so it leads to symptoms across these 4 domains. So cognitive, That's going to be the racing thoughts, the worry, the mental activity, the worst case scenario thinking styles that come. Physiological symptoms, right? That increased heart rate or tension, restlessness, inability to relax, certainly panicky feelings. Affective, such as worry, fear, apprehension, irritability. And behaviorally, that's where we can see either kind of withdrawing or isolating, increased, decreased sleep, certainly using substances as a means of coping. Now, there's a difference between state anxiety and trait-based anxiety. So state anxiety is going to occur really specific, kind of situationally or to the context. Okay. Trait-based anxiety is going to be where there's kind of a negative emotions across multiple domains, kind of this persistent or enduring interpretation of something as a threat. And I should clarify that when I'm talking about kind of this idea of a threat, it doesn't necessarily mean physical threat. It could certainly be physical threat, safety, psychological safety, ego, relationship stability, abandonment. It can be any type of perception of harm or threat that can come. One great example of state-based anxiety is pregnancy-specific anxiety, right? Fear specific to the perinatal period. How's pregnancy going? How's the baby's health? What will labor and delivery be like? How am I going to adjust to motherhood? So certainly understandable and pretty normative to have some element of anxiety in the perinatal context or during pregnancy. However, in the next slide, I'm going to talk about generalized anxiety disorder, which is a more clinically significant presentation. And honestly, this pregnancy-specific anxiety can reach levels to be as severe and impairing as GAD, as generalized anxiety disorder, as we touch on. So we also can kind of see this almost as like this kind of pivotal time or turning point where an individual woman might be kind of primed or predisposed to kind of anxiety, and how they navigate, again, this time of like, again, the unknowables and uncontrollables in pregnancy, how they deal with that uncertainty, how they deal with the loss of control can potentially kind of influence, does this stay pretty pregnancy specific and improve over time, or does it persist and just kind of the focus of it change and it goes into more of a generalized anxiety presentation? So generalized anxiety disorder, kind of the classic criteria for this is this excessive, difficult to control worry that's really time consuming, intrusive in nature, can lead to irritability, tension, disrupted sleep. The clinical criteria for GAD requires that it is occurring for 6 months. It's a pretty long duration. And there's some literature that says actually we increase the specificity of the diagnosis if criteria in a perinatal population, if the criteria for this is met within 1 month. And so I think kind of starting to view it in those lines can help us capture women that we think kind of this normative pregnancy related anxiety, but they might be inclined in developing more of a generalized anxiety disorder, which is going to really warrant at least therapy or medications, potentially, to get more optimal treatment. So kind of a distinguishing feature is that worry about everything. That's why there's the whack-a-mole, right? No amount of like reassurance really helps. They get past one, you know, they get out of the first trimester and, oh, that's good. And well, now it's just getting to the anatomy scan, or it's getting the viability, or whatever it might be. So it's kind of that moving target where, again, no amount of reassurance or evidence will kind of satisfy kind of that anxious brain. So definitely kind of that intolerance of uncertainty is present. Sometimes it's also some personality traits like just high or unrealistic expectations for oneself. Because that not knowing is so uncomfortable, and that anxious brain convinces them like, just worry. Worry will help, right? Because then you'll be prepared. And if you're prepared, then you have some false sense of control about things. And so that kind of just starts then perpetuating a vicious cycle, which will kind of be highlighted a little bit in our next portion that we talk about. If GAD presents with depression, it tends to be a more severe and protracted course for a woman. So it's something to be mindful of. And generalized anxiety disorder is one of the strongest predictors for postpartum alcohol consumption. In fact, in the general population, it's one of the most common psychiatric comorbidities for substance use disorder. So definitely something to be mindful of that can predispose to increased use of substances postpartum. Then there's OCD, which, you know, at face value can kind of look similar to GAD. The difference is going to be a couple different things. The kind of obsessive worry, racing thoughts that occurs in OCD, it's going to tend to be a little bit more irrational. Where generalized anxiety disorder, they still might not be likely to happen, but could be a little bit more kind of like reality based. But in OCD, they're going to be more irrational worries that are so distressing that the individual kind of copes through these compulsive or ritualistic behaviors. Again, it has to be pretty time consuming. So it's a minimum of an hour a day on these compulsive acts to try to get rid of that discomfort that comes from the anxiety as a result of that. Those intrusive obsessive thoughts. It's relevant because pre-existing OCD often worsens in pregnancy. And if you recall earlier on, I said that an antenatal OCD certainly is going to predispose to then an exacerbation of anxiety in the postpartum period. And postpartum OCD can tend to have even more rapid onset. Probably not too surprising, you know, most commonly, especially postpartum, the focus of the obsessions tend to be like infant well-being, kind of the safety, contamination, harm coming to the baby. So it can be pretty distressing for women. In comparison to like some of the other anxiety disorders, we see a little bit less robust relationship between OCD and substance use disorders. Some of that is believed to be that these individuals tend to be more harm avoidant, so less impulsive, less risk-taking. And it tends to be if an individual with OCD is using substances, they're going for more of the sedating substance use. I have to put a plug in for intrusive thoughts. This is relevant for anxiety disorders, but definitely relevant for any woman that's having a baby. So super common to have these intrusive thoughts. About 90% of women after having a baby will endorse having intrusive thoughts. If you're not familiar with them, it's kind of those bizarre, random, fleeting thoughts or images that kind of come to mind. What if I drop the baby as I'm walking down the stairs? Or what if as I'm going by the garbage can, I've dropped the baby in? Or what if as I'm in the kitchen, the knife kind of flies off the counter? This is very different than kind of those thoughts that occur in more of a psychotic spectrum presentation where a woman is not distressed by those thoughts and then therefore could act on them. That's much less likely, occurs much less frequently rather. These are distressing to the woman. And so sometimes she doesn't verbalize them or she doesn't because she's so kind of embarrassed and shameful. But psychoeducation goes a long way. So I think it's really important. There's a few things if you're seeing women perinatally, educating them on the baby blues period so they understand what's happening at that point in time, and certainly providing some good psychoeducation on intrusive thoughts. Definitely be pretty normative, understandable. Women can have them. Doesn't mean there's anything wrong. You just want to work on labeling and kind of detaching and kind of regrounding from the thought. And so I think that that's really helpful. Certainly if it's much more severe of a presentation, it could be more indicative of OCD. And then again, kind of mental health treatment to address that would be important. And then the last specific diagnosis that I will touch on is PTSD. So this requires the direct or indirect witnessing of that traumatic event with kind of a cluster of symptoms around kind of hypervigilance, intrusive thoughts, negative thoughts or mood symptoms. and kind of avoidant behavior. In the general population, adults with PTSD are 2 to 4 times more likely to have a comorbid substance use disorder compared to those without. So again, something to have on your radar and being mindful of the relationship between it. PTSD in the perinatal context, so that can kind of be either, it could be one of 2 ways, right? It can be that a woman's coming into pregnancy having a trauma history and having a diagnosis of post-traumatic stress disorder. And then we need to be mindful of, is there anything within kind of the pregnancy, labor, and delivery experience that could exacerbate that trauma for her? Or it can be new onset PTSD as a result of a traumatic event, either pregnancy loss or traumatic delivery experience. Again, so that kind of that distinguishing feature, but what I want to highlight is we cannot clinically diagnose PTSD until about 1 month after the event. Majority of individuals that go through trauma recover and they don't develop PTSD. And I'm pointing that out because I think PTSD has kind of become this more commonplace verbiage that we're used to like describe a reaction. And we lose sight of the fact that it's actually a clinical diagnosis. So we do want to recognize when it is clinically significant and then intervene. And we also don't want to discount the fact that, again, we are allowed to have, a period of time of quite a range of emotions after something traumatic. And it doesn't mean it's necessarily PTSD. So again, perinatally, we want to be mindful of potentially anything that could trigger the trauma history for a woman. We want to be mindful if there is any substance use history, the potential for relapse or recurrence of issues around that. And then especially having disrupted sleep in the postpartum period can worsen trauma symptoms. From a differential diagnosis perspective, certainly we always want to rule out anything medically that could be occurring for a patient. I had a woman recently within the last year. She came in, she was postpartum, and she was a nurse, so she kind of had that knowledge. And I can't recall specifically, I think she may have already started Zoloft at the initial appointment that I was seeing her. And she definitely had a lot of kind of classic anxious tendencies that were not uncommon for a new mom, but there's just a flavor to her anxiety that felt different to me, kind of like she was buzzing and vibrating, and talked about it with her OB provider. And ultimately, she was diagnosed with thyroid dysfunction and started on Synthroid, and that in combination, it wasn't all of her anxiety, but it was definitely a large portion of her anxiety. So wanting to rule out anything medical, such as thyroid or anemia or other factors, certainly more acute medical conditions in the case of kind of new onset, severe anxiety or panic symptoms would be prudent. Psychiatrically, we are trying to kind of do that differential through some of those presentations that I've already touched on. Again, is this kind of pregnancy specific anxiety, or is it more clinically significant GAD, OCD? Is it more indicative of trauma? Or again, is there substance use at play? And if so, how does their anxiety relate to their patterns of substance use? And is there any period of abstinence that we're able to kind of evaluate their anxiety symptoms? From a treatment perspective, I say whatever the patient's willing to do, right? So if they're inclined for medication and that's something that is going to work for them, that's great. If they want to do therapy, that's great. Whatever path or inroad into treatment they're motivated for, I think is a good option. Generally speaking, if their symptoms are more mild into moderate, first-line evidence-based psychological interventions is good to do kind of as a first step. Or definitely if there's more moderate or severe symptoms, having the combined medication and therapy is going to be more optimal outcome. Okay. If we're still doing well, we're going to move on into some of the core processes of anxiety disorders and kind of give you some of the, again, those underlying kind of cognitive and behavioral factors that contribute to anxiety. There's a lot of different ways we could kind of illustrate this. I think this alarm belief coping model is pretty nice and simplistic, an ABC model, so there's that alarm, right? There's something that kind of triggers that initial kind of interpretation of it. It could be a situation, conflict with a partner, upcoming OB appointment, decreased fetal movement, or it can be a feeling that they're having, other thoughts that they're having. This leads into their beliefs or interpretations of that kind of trigger or alarm, how they interpreted it. And that's going to be based on their personal experience. And in anxiety disorders, again, it's going to be interpreted with a kind of a dangerous or kind of a threatening quality to it. Either something bad is going to happen, I'm not going to be able to cope with it. And that leads into coping. What do they do? Is it helpful? Do they breathe? Do they talk to their support system? Is it an adaptive coping response? Or is it maladaptive coping, which we will touch on, that kind of perpetuates kind of the cycle of anxiety? I'll draw this a lot for patients because I think it's pretty I tend to be pretty visual, and I think it helps give them some insight into kind of behavioral factors of anxiety. So again, something, whether it's some external event or some internal thought or feeling, triggers that fight or flight or anxious response, right? The alarm goes off and an individual is feeling worried, overwhelmed, physically uncomfortable because of that anxious response. Well, people are smart. They're going to do what they need to do to keep themselves safe or feel better. And so it's at that level of when that alarm goes off that they then engage in these kind of anxiety-driven behaviors. So the individuals that are doing a lot of checking behaviors. So simplest example of that is like checking in the baby pretty frequently. But it could be all sorts of different things. Checking physical health symptoms, the reassurance seeking, asking family, friends, their provider, going on the internet and going down the Google rabbit holes, ruminating on things, using substances. All of this is done as a means of trying to kind of tamp down that discomfort that's coming from that alarm. And it does, it kind of works, like just enough short term that learning takes place. And that learning is that high anxiety, I do these behaviors, and then I feel better. I feel safe. I feel calm. I'm okay. And so it's this learned pattern of trying to kind of get rid of, avoid that discomfort that comes in response to whatever their personal triggers might be. Caveat is we're not designed to stay at that high level, and we would come back down even without doing those behaviors. So as a result, right, even though these give like some short-term relief, they lead to anxiety at minimum kind of persisting, if not even worsening at times. It's not to say that any of those behaviors are necessarily bad. It's just if they're always done in the service of trying to kind of get rid of that discomfort and the individual doesn't have kind of a scope of coping beyond that, then it's not going to serve them or be very helpful. And then we have kind of the thinking element, right? So how an individual interprets kind of that initial alarm or trigger situation. Generally speaking, anxiety is going to be future focused, thinking about something ahead. Not exclusively, because certainly it could be driven by like rumination on past things that have happened, but tends to be a little bit more future focused. The anxious brain also overestimates the threat. Something bad is going to happen, and it underestimates coping. There's no way I'd be able to deal with it. And so it leads to that kind of, again, kind of paralyzed, fear-driven feelings by which then that individual engages in some of those unhelpful behaviors to try to get rid of it. And so, right, it's not always likely going to be the worst case scenario. You are probably going to be able to cope with it. And so treatment is really I'll touch on cognitive behavioral therapy in a second, That's really what we're trying to get at with CBT interventions, is to be able to kind of like walk back that overestimation of the threat, being able to develop more realistic, kind of middle ground, flexible thinking patterns, being able to build up some self-efficacy for coping. So future-oriented, kind of overestimate the threat, underestimate coping, and finally, kind of this overvaluing thoughts and feelings. So that's kind of the quality of, if I'm thinking it, it makes it more likely to happen. Or if I'm feeling it, then it means it's true. So if I'm feeling anxious, I must be in danger, or something bad is going to happen. If I'm having the thought that there's something wrong with the pregnancy, then it means it's likely to be the case. Kind of giving thoughts and feelings more credibility than maybe overvaluing them than we should, or that is helpful. Okay. We can have all sorts of thoughts and feelings. They're true in the sense that you're having them, but they're not truths. And so that is another mechanism of treatment that allows for kind of intervention. So let's talk about some of those evidence-based treatments. We're going to go through 3 of them, and I'll just kind of highlight some. Cognitive behavioral therapy, CBT, it really gets at kind of that interpretation, those faulty thinking patterns that occur in an anxious brain. It has great empirical support, great first-line treatment, and with antenatal anxiety, kind of mild to moderate anxiety in pregnancy was decreased and sustained into the postpartum period. So definitely effective for anxiety, also effective for substance use disorders. And again, it's really getting an individual to be aware of what are their triggers. When they're triggered, what is their interpretation style? And are they thinking through things, again, in a realistic, balanced way? And are they engaging in behaviors that are adaptive and helpful versus maladaptive and kind of perpetuating the cycle? So modifying their thoughts and modifying their behaviors to kind of break that anxious circle. In addition to cognitive behavioral therapy, we can add in some components of mindfulness or acceptance-based treatments, or there's some great evidence-based interventions like acceptance and commitment therapy that really just focus on more of those mindfulness and acceptance-based skills. And that's going to be really building, again, countering that future-oriented thinking style, building more of that present-focused mindful awareness, instead of kind of, again, that overvaluing of thoughts and feelings, being able to get some space and recognize that you have thoughts and feelings, but not necessarily acting from that place. So present focus, aware of the thoughts and feelings, but taking action more in line with values rather than kind of emotions, fear, anxiety. And again, good data from kind of the perinatal literature on mindfulness-based interventions, reducing negative affect and anxiety, and increasing self-compassion. Probably for the last like 6-7 years here, I've offered an 8-week mindfulness-based cognitive therapy group for women, kind of in that reproductive spectrum. And it's time intensive. It's Tuesdays from 4 to 5:30. For 8 weeks with at-home skill practice, sometimes up to like an hour a day. It is one of the most gratifying things I get to do. I love it. I have my final session with my current group this evening, and women across the board have shown from week 1 to week 8 a reduction in depressive and anxious symptoms and an increase in their self-efficacy for coping. So it's a really nice treatment option. And then last, also with strong empirical support along with CBT, is interpersonal therapy. This covers kind of interventions in, like, let's say 4 buckets, right? So it looks at role transitions, right? Really relevant with this identity into transition into motherhood. It looks at role disputes. So kind of those changing roles and relationships with partners or family members. Kind of this communication skill deficit challenges that can happen, and then grief and loss. So what this evidence-based treatment really focuses on really highlights a lot of potential challenges for women in the perinatal context, so it can be very helpful. It views that, yes, kind of problems occur on an individual level, but it's a function of their social and interpersonal context. So it starts to, whereas I think CBT and mindfulness-based practices really look at kind of that individual level, interpersonal therapy starts to bring in kind of the social context that also contribute. All right. I won't go into this too much, but certainly screening can be incredibly effective. It detects symptoms early and allows, issues to be brought to light that maybe a woman might not otherwise bring up readily, or again, might not perceive it as problematic until kind of this dialogue can start around it. Generally, about 50% of OB providers do screen for mood symptoms, but the screening tends to be more on depression, not anxiety. And so we want to make sure that there's some good kind of either just questions that we can ask women or some screening measures to use, again, to start to kind of bring this to light and to see what extent anxiety is present for them. EPDS is a great one. I'll show you at the next slide. GAD-7 is also another nice option. Don't want to make an assumption that everyone kind of on this call, maybe you know this, maybe you don't, but it's a brief 10-item self-report measure, removes kind of the physiological symptoms that can overlap kind of medical and mental health, such as sleep, appetite, energy. I like it because it's brief, but it also has that item 3, 4, and 5 is that subscale for anxiety. So you can really see if those items are driving their overall score and kind of get it's a quick, easy to use snapshot and can kind of get an idea on whether it's more anxiety based or depression. So how can we support women kind of in medical settings, and can you use some of these CBT interventions? Psychoeducation is going to be huge, right? If women can start to understand what is going on with them, why they're experiencing what they are, being able to kind of get some understanding of what is, again, that normative situation specific anxiety versus when is it more of that clinically significant and the impact of that, if it is. Even giving some good psychoeducation on even like a simple CBT model really lays the groundwork for that to be incorporated in some medical visits as able. Handouts, book resources, I'll have some of that on the next slide. Also good, or app-based resources. There are CBT-based apps, or some health systems have kind of more of those tech or mobile-based resources as well. It can be something as simple as incorporating simple breathing practices into visits, whether there's any medical procedure happening or not. Already you're starting to kind of counter and build more of that adaptive coping behaviors for a woman. It can be helpful to, if someone is really highly anxious and very emotive, scheduling just more frequent visits as anchor points, kind of preempt some of that worsening anxiety. Again, if we can kind of give them some education on that ABC model and some of those slippery thinking patterns characterized in anxiety, can be helpful in bridging into some thought challenging. Is there evidence for this thought? Is there another way to look at it? Okay, if that did happen, how would you cope? Things of that nature. And then used in primary care, AWARE is a simple acronym. A is supposed to actually be accept, but I think that can come with kind of highly charged connotation. So I think acknowledge is sometimes more amenable for people. This is a little bit more of that mindfulness-based, acceptance-based approach of being able to kind of acknowledge that you're feeling anxious, be able to be out an observer of it, be able to act in a way that is going to serve you, even if you're feeling anxious, and to kind of keep doing that. And these are some of those resources, specifically that first one is kind of general anxiety, but the second one is also a really nice workbook that patients can pick up on on Amazon. I think it's pretty reasonable, and it goes through a variety of these skills for them. And again, all of the examples are going to be in that perinatal context, so very relevant. That's what I got. Thank you.
I want to open it up to any questions if anybody has any, or you can pop them in the chat as well. I guess I have a question I'll start with. I have like 5 questions, but hopefully somebody else will ask the same ones. I think the big ones are, you know, a lot of times you come in as an OB and you have like 15 or 20 minutes, and obviously my patients are maternal fetal, so there's a little bit higher risk. But when you feel that palpable anxiety in the room with the patients, are there things that you've noticed in talking to your patients that we do as OBs that are unhelpful, or things that we do that are more helpful?
Ooh, that is a good question. I think the first thing that's coming to mind that I know when they find helpful is when they feel as the provider is present with them, even when time can feel so limited, translating, so sitting down, helping them kind of, or allowing them to feel as if you have that time for them. And then for you as a provider, being able to have some of those nuanced skills of how to optimize and use that time in a way that's not feeling like you're opening up kind of a can of worms that you can't put back together, which can be kind of a barrier sometimes to kind of exploring more of the emotional experience for a patient. So I think, yeah, whatever you can do to convey being there for the patient, present, that you do have the time for them. I think a good key question that can help is what's troubling you the most, because 2 things. One is it lets you focus on what's the most primary issue and kind of funnel down to that. And you can really even tell them, you know, we don't always have kind of the bandwidth in a visit to cover everything. So for today, what's troubling you the most? And that's kind of starting to set some of that boundaries too as well. But the other way that that question is helpful is sometimes we think it's our own assumption of what the patient is troubled by, and it might not be that for them. And so you'd be surprised that if you ask that question and just really hear where they're at. And so it allows you to really kind of hone in on what's going to be most relevant for them. So what's troubling you the most?
That's super helpful. And then the other one I want to make sure I get answered to as well is also is as a MFM, but I think for any OBGYN, there are a lot of traumatic things that can happen. And I'm sure you see a lot of the patients in the aftermath of that, you know, unexpected pregnancy loss or, you know, very traumatic birth histories. If we have a patient who just went through that, are there things that we can do, or, you know, referring to someone such as yourself, that will help reduce the risk of them developing PTSD after that month?
Mm-hmm. Really, I love these questions. I think what you do that's most helpful is being there to provide that support. I think normalizing it. Sometimes what can worsen kind of how an individual might respond is kind of the fear of how am I going to navigate this? And so allowing them that space for having that reaction. I mean, sometimes I'm called in to go see an inpatient consult, and it's with the guise of that this woman isn't coping appropriately, or that she's having this kind of trauma reaction, and we lose sight again of what's understandable, right? What can that human experience, what that human experience can entail. So really normalizing their symptoms, allowing them to have the space for that range of emotions, being there as support, letting them know that there are resources as they kind of move forward with it, I think are all pretty helpful strategies, versus kind of jumping into kind of some of the messaging of what they're feeling isn't right or expected, or is clinical or problematic, or that they need to do mental health treatment. Giving them a little bit of that grace period, I think, can be helpful.
Any other questions?
I see one from Rochelle Power in the chat. I'll just read that, Dr. Kruper, so you can hear it. It says, I'm very much interested in being an embedded CNM and PMHNP provider in a private practice clinic setting, but I found community resistance from MDs in my area of Colorado. Our population could really use the resources. How can I circumvent provider fears by bringing someone such as myself into their practice?
Can I ask a clarifying question? What are the provider fears, or what are some of the concerns? Be able to get that information.
Yeah. Rochelle, I don't know if you're able to unmute yourself. You're welcome to do that. Otherwise, if you want to throw that in the chat.
Yeah, sure. I think part of the problem is that, so this is Rochelle. Hi, nice to meet you. I think part of the problem has been that there's this perception that women gravitate towards midwives, and we're not very cost effective in our production of practice. And so MDs really want to protect themselves, despite the fact that women are calling for these resources to be in place in our community. I'm out in Colorado Springs in that area, and we haven't had nurse midwifery, let alone psych mental health nurse midwives in practice in Colorado, and this part of Colorado, since 2017. And there's a number of us who are duly certified as CNMs, psych mental health NPs. And there's just, the bottom line is when it comes down to it, and it's really unfortunate because even our birth center here that's run by certified nurse midwives don't want to integrate us either. And it comes all down to money, unfortunately.
Yeah. Some of those systematic factors that feel a little outside of kind of my own scope, but are real and present in a variety of ways in different situations. I mean, I think persistence is key, and bringing some kind of information to the table as far as how the collaboration and presence does improve patient outcomes. And sometimes, people need to hear the same thing, but in different ways at different points in time to kind of move things forward. But certainly sounds like kind of a challenge from a systemic perspective.
I would say something too that helps just when you're introducing something like this, because I think from a outcomes basis, this is only going to help patients to have someone who can care for them from an obstetric perspective and can address their mental health concerns in a productive way. Is finding a champion, whether that's a prior patient or, just one of those providers, midwife, physician, whatever, who either has a personal experience where these needs weren't met together or has a personal experience where they were, and trying to get that person to really say, no, I think you're looking at this from the wrong perspective. Not an easy thing. And you probably have to go through a bunch of potential partners or advocates or champions before it would happen. But it's certainly something I've seen help when we're trying to integrate, addiction medicine or mental health into our services.
That's great. Thanks. Yeah. And we just had a new resource home, residential home open up for pregnant individuals with substance use disorder, but they are operating under the pretense that they're going to farm a lot of those resources out for OB care and psych mental health care, mood disorders and substance use to the community, which is unfortunate because integrating somebody such as myself means I get the full clinical picture with hopefully better outcomes. But the social workers who run the program aren't interested at all, no matter how much I talk and plead about it.
I think Marla has her hand up for a question.
Yes, I do. I just wanted to share something. I work as a nurse in the ER, and we had a patient come in probably like 2 a.m. With anxiety. She was 4 months pregnant. She had an ectopic pregnancy maybe 6 months earlier. And the doc just rolled in with, the ultrasound, showed her the baby, showed her the heartbeat, and just kind of let her settle in with that and gave her reassurance. Mm-hmm. So I was talking to him later and I said, I really like your style. That really helped her in that moment. So it kind of like let her know the baby's okay. And it's okay to like have those feelings. And then she was dischargeable. We ran some, I can't remember what he did like lab wise or anything, but it worked out really well. I was impressed.
Nice. Thank you.
Yeah, I definitely think sometimes, at least I see it more traditional obstetric venue, is this idea that like something's not necessary. Like, well, she doesn't need that ultrasound, or she doesn't need to come weekly for visits, but you're looking at it just from a medical and not from a mental health, or even for substance use disorder. Whether I tell a patient it's okay to be on methadone in their pregnancy or not, seeing their baby on the ultrasound, hearing that strong heartbeat often I think saves a ton of anxiety for the patient. And it just, but sometimes you'll see that provider say, well, no, I know better than you what you need to be healthy. And I learned that often I'm just like, let's just, like you said, Marla, like, let's just pop the ultrasound on. Look, everything looks great. And it can just make such a difference for that patient.
Yeah. And I think that's such a beautiful example of like this being with. And I think Dr. Kruper was kind of, acknowledging Dr. Jones, when your question to how can we as OBs or MFMs sort of, or anyone in that delivery room, kind of buffer any of the trauma. I will constantly hear from mothers who have had a traumatic delivery and describe it as such, and yet are able to say, and I felt very heard and validated by my team. This was still the outcome. This is still how I felt, but I felt held and listened to during that. And that has been such a pivotal, positive shift in their treatment and their healing. And it's sort of this example that Marla brought up too. It's just like, it's the human thing, right? Like you're being with, and you're not, I think the validation gets hard because you don't want to validate, the anxiety that might not be true, right? But you're validating the emotion and that they're feeling this way, and you're there with them.
It's such a great comment and so important. Absolutely, that, there's ways to help them kind of understand kind of that perspective and flexible thinking, but never with the goal of trying to talk them out of their feelings. And so kind of that validating their feelings and bringing in some of the perspective is great, but absolutely important to emphasize that the validation of the feelings is huge. And then bringing in, okay, what do we want to do about it? What are ways that we can kind of approach this?
I would say on that same note, something, and I think it's not necessarily Midwest specific, but it happens more in the Midwest than where I've worked previously. And that's this whole idea of minimizing or invalidating your own feelings. When someone tells you their trauma story in Minnesota, what they'll say is, oh, I'm so sorry that happened to you. And they say, it's okay. And so I've really, as I have more trauma-informed education, I'll say, well, no, it's actually not okay. But it's just this knee-jerk reaction, like, I got in this near fatal accident. Oh, I'm so sorry that happened to you. It's okay. And trying to say, I want to validate what happened to you. That sounds really scary. And, it's okay to say it's not okay. But I see that I would say more here than anywhere else. And it's just, because feelings or emotions or trauma is so uncomfortable, it's easier to say, oh, it's not a big deal, when really it is.
Or like the women that show up in my office and they're crying and then they're apologizing. Nope, that's why we're here. There's no apologies for emotions.
Dr. Kruper, I just had one question. It's something I'm still learning and trying to navigate as a psychiatrist. Often, kind of along these lines, women or parents will come in and say, well, I know there's some normal anxiety, right? Like, of course, I'm worried about my baby, of course, right? And so how do you know? I get the question, how do you know when it's not normal? Like, how would I know? How do you approach that or talk about that with families?
Probably pulling a little bit on like motivational interviewing. I'd get them to try to talk about, well, how do you see anxiety not working for you? In what way has it been problematic? Really start kind of asking the questions in ways that highlight the patient talking around, why is it not helpful? How is it not helpful? Why is it not serving them? And the challenges that come. Or I try to kind of, how would you want to see yourself showing up in this situation? So either kind of getting the dialogue not to be why it's normal, but getting the dialogue to be how is it problematic and how do they want to see themselves? So anchoring into those two other points tends to be what I rely on.
That's really helpful. We had a session on motivational interviewing in this series, so it's perfect.
It's a very worthwhile tool.
Yeah.
I want to just call out too, that's something that you said at the beginning that was so helpful. This is just sort of the same thing where you're saying, what are your goals and how can I tailor it? Is when you said the best treatment is the one that the patient thinks might help or is willing to try. And that's a very new thing in substance use disorder treatment where, we walk in and say, I know these are the two best treatments in pregnancy for your opioid use disorder. And a patient says, that's great. I want to do medically assisted withdrawal and not be on any medication for opioid use disorder. And telling them they need to do something different is often not helpful. So I appreciate that you use that same philosophy that we are finally starting to use in substance use treatment.
Thank you.
Any other questions anybody has? I know we don't have many, we only have 3 minutes, so we won't go into the case because I don't want to run too far into people's next clinical session, which is probably what will happen. Anything else? All right, well, I want to thank all of you for attending today and look forward to seeing you back here in a couple of weeks.
Thank you.
Thanks, everybody.
Thanks, Abby.